Psychiatry Bootcamp. This is part 2 of an Awais Aftab double feature, and this episode is going to draw heavily on Dr. Aftab's recent essay, 6 Suggestions for DSM-6, which is linked in the episode notes. Dr. Aftab, since before our first conversation, I have described you to friends and colleagues as the person who I think should be chair of the DSM-6 steering committee. I'm not exaggerating, so I'm especially honored to be having this conversation with you. A couple of intro questions before we get into your 6 suggestions. Why does the DSM change?
Oh, okay. All right. That's a big question.
I know. I'm sorry.
One simple reason simply is that our clinical and scientific understanding changes over time. So DSM has been around since the early 1950s. If you look at the span of 70 years, the thinking in the field about how to talk about mental disorders and what disorders to formally recognize and what do we know about them in terms of their epidemiological features and clinical features, etc., all of that has evolved considerably and expanded in different ways. So some of it is just practical necessity that we have to do a kind of periodic update of clinical thinking and express a statement of the consensus of how the clinical community is thinking about these things. So that, I think, has accounted for the revisions. I think there has been some more, skepticism and hesitance about revising DSM in the 21st century, because at the end of the 20th century, when DSM-5 was being developed, there was this hope that the next classification manual that we have, that would be neuroscientifically based and etiologically driven. So a lot of people, when it came to DSM-5, were hoping for a paradigm shift. And by the time DSM-5 came out, it was clear that that was not going to happen. Science just hadn't advanced enough. So the more neuroscientifically oriented psychiatrists, some of them were of the view, well, why revise if we don't have the neuroscientific answers yet? So I think right now, given the state of the field, I think there's a pro camp and an against camp about whether it makes sense to revise or no. But I think for much of the 20th century, it was just a response to evolving understanding.
Yeah, now that I think about it, just about every textbook needs to be periodically updated. So maybe that was an overly simple question. And also, I'll comment on one thing you said, which is that the neuroscience has not evolved to the point that we are able to make this sort of a strictly neuroscientific document and make classifications based on biological processes. I would argue that we're never going to, and my audience can feel free to throw tomatoes at me. And I hope that maybe in 100 years I'll sound really stupid, but I highly doubt it. I think that humans and human behavior and human motivations and the patterns of behavior that we display over time are just more complex than neuroscience. And maybe that sounds silly to some, but I'm happy to die on that hill.
I agree with you. I think we can get to a point where we'll probably have a classification that is decently informed by neuroscience, but I don't think we'll have a mainstream classification of psychiatry which primarily revolves around kind of neuroscientific mechanisms.
Second of 3 intro questions. Just brief overview, if you don't mind. How does the DSM change?
So DSM is owned by the American Psychiatric Association. So it's a process that's very much driven by the APA, and they decide how they want to do it. And there has not been a uniform process for the 5 DSMs so far. All of them have, the exact stages and process involved have been slightly different for all of them. In general terms, what happens is that the first APA has to authorize that they're going to create a new version of the DSM, and once they authorize that, a task force is created, which usually includes very, very senior and distinguished individuals. So I'm flattered that you think I should be on it, but I'm too early career for, and that would be a surprising thing that if it happens. But anyway, so there's a task force of distinguished and senior clinicians and other researchers who have some kind of a vision for what that manual is going to be, that implicitly APA is also on board with. They feel like, yes, whatever vision this task force has, we endorse it. And then that task force creates a number of different work groups. And oftentimes those work groups are organized around diagnostic lines, where let's say there's a work group for mood disorders and one for anxiety disorders. The exact will change from room to room. So work groups will conduct extensive literature reviews and review scientific evidence and clinical evidence, and they'll make proposals for what needs to change or what kind of new categories need to be considered. And then those proposals are hammered out, and there's a lot of negotiation and discussion In the DSM-5, they also added other layers of scrutiny where proposals from work group had to be reviewed by a scientific review council. And they also had a council that looked at issues of clinical implementation and clinical utility. And so they also kind of had to give them their, okay vote or, offer their assessment. And then it comes to kind of APA at large and the APA has to decide whether to approve or reject those changes that have been proposed by the task force. Once the work groups have finalized their proposals and they've been endorsed, by them, they are open for public comment. So APA usually posts them, and there's a time period in which any concerned person in the public can comment on those changes.
I think that speaks to what an important document the DSM has become, not just in the practice of clinical psychiatry, but for a lot of different things, forensic issues, insurance, billing, etc., not to mention self-understanding. Diving into your 6 suggestions for DSM-6, I want to start by picking on one of your assertions. So I'm going to quote you to yourself. I'm sorry to do this. You're right. Obviously, for a lot of people, including many philosophers and psychiatrists, calling something a mental dysfunction is a much stronger claim that says something about failure of a natural design or neurophysiological alterations, etc. For them, it's not just, oh, you're suffering in a way that is socio-culturally atypical, and we have clinical interventions that can potentially help you. So you're saying that for the way we use the word disorder, it carries with it these implications of specific neuropsychiatric pathways that are aberrant, rather than the way that we might optimally understand the word disorder, which is that you are suffering in a way that is socially, culturally atypical, and we have clinical interventions that could potentially help you. So my question, really, do you really think there are people with professional clinical training who interpret the word disorder to imply that there are necessarily neurophysiological alterations present?
The issue comes down to, I think, people's understanding of how the disorder concept should be appropriately understood. The folks who understand disorder concept in these more strict terms, thinking in terms of either failure of evolutionary design or thinking of it as being atypical in a biostatistical sense from species level functioning, or thinking in terms of brain circuit dysfunction, etc. They recognize that yes, like DSM currently using these categories in a symptom based manner, that the explicit criteria do not refer to either failure of natural design or neurobiological abnormality, etc. But the thing is that they think that is the right way to understand the concept of the disorder. So they think that either the DSM is simply mistaken in how it is using that term, or they think that there's actually a hypothesis hiding behind it, that people behind the DSM are actually hypothesizing that yes, there are these neurobiological alterations that we will find. We haven't found them yet, but they think that the hypothesis is there, and maybe it's a false hypothesis or maybe it's a true hypothesis, but that's a kind of guiding idea behind it. A lot of, I think, there are many philosophers who take that kind of view. There are many psychiatrists who take that view too, and I think this kind of thinking about disorder is particularly appealing and attractive to people who work in evolutionary psychiatry, because from an evolutionary perspective, there's a clear distinction between symptoms that are caused by intact mechanisms that are doing what they were naturally selected to do versus mechanisms that are experiencing some kind of breakdown of the function that they were designed to do. So, think of it in terms of anxiety. Anxiety is an evolved function. We evolved to experience anxiety because it's a signal of threat and danger. So we are predisposed, evolutionary speaking, to have a certain degree of apprehension and generalized worry. We are predisposed to have, certain experiences like panic attacks, because they serve an evolutionary function. And people who were not anxious in this kind of manner, they did not survive in the course of evolution because they did not take the right kind of precautions that they needed. So for a person experiencing anxiety, from an evolutionary standpoint, some of them are basically experiencing exaggerated version of an evolutionary design response. And some of them are experiencing a threat system that is malfunctioning in some way, that has veered off the course of what it was evolutionary designed to do. You can divide the group into those kind of people. And a similar thing with low mood. Low mood is also an evolved mechanism similar to like a cough and fever and pain. And so some people are experiencing low mood because that's an appropriate response to their situation. Versus for other people, it's kind of like, their low mood is abnormal in an evolutionary kind of sense. So you can see how, the evolutionary psychiatry folks would be attractive to, thinking about that. But that is not the way in which DSM uses that term. And if you think of the general public and you think of, well, how do people think of the word disorder? They tend to think of it in those strong terms of abnormality, that something has gone wrong in some kind of neuroscientific mechanism sense, that something in the brain is not kind of doing what it is supposed to do. And I think a lot of people, even a lot of psychiatrists, don't realize that the DSM definition or DSM way of thinking about disorder is basically in terms of socio-culturally atypical rather than some other kind of reference.
I'm interested by that because my understanding was that DSM defined a disorder mostly by dysfunction.
It does. So there are two elements to the definition of a mental disorder. The first element is dysfunction, which kind of refers to the idea that something has gone wrong in some sense. So you need, one, a dysfunction in biological, psychological, or developmental processes associated with mental functioning. The second component is distress and impairment, that either the person is experiencing, very significant distress by it, or their day-to-day life is very affected, their day-to-day functioning is affected. The challenge here is that I think when a lot of people think about dysfunction, they're thinking of functional impairment. They're thinking of, kind of DSM is talking about impairment, disability. It's talking about the negative impact on life. But that is not what the term dysfunction means in the context of the mental disorder definition. And that's also not how philosophers use that term. If you look at kind of philosophical work in kind of definition of disorder, dysfunction is not understood as being functional impairment. Dysfunction is understood in terms of either mechanism failure, understood in terms of some kind of abnormality. So think of it this way. Think of the criteria for generalized anxiety. So, you have excessive worry that is persisting and that, it has a certain number of symptoms, 3 out of 6 symptoms for 6 months. And that kind of excessive worry causes, or is accompanied by significant distress or functional impairment. So there are two elements. One is the excessive and persistent anxiety part, and the second is the distress and impairment part. And so when DSM talks about dysfunction, it is the excessive and persistent anxiety that is the dysfunction. And how do we know that anxiety is excessive and persistent? It's just our commonsensical, intuitive, folk psychological standard. The person feels it's excessive. The clinician agrees it's excessive with reference to something. So when DSM defines disorder as being a dysfunction that is also distressing and impairing, the intended meaning of dysfunction is something along the lines of an abnormality of some sort. It does not mean functional impairment. And I think this is the point which I think confuses a lot of people, because they think dysfunction and they immediately think, it's negative effect on day-to-day living. But that's not that's not the intended meaning.
That's the more folk psychological understanding.
Yes, I think folk psychological understanding is kind of mixed. I think a lot of clinicians focus on distress and impairment as the kind of driving consideration. I think they recognize problems as being problems based on whether the person is distressed and impaired. But historically speaking, that is an unusual way to talk about disorder. I think when a lot of people think of disorder, a lot of, I think, lay people, they're thinking in terms of abnormality, that they're not just thinking, so if someone says, hey, I have an anxiety disorder, it's not just, hey, I'm anxious and it's negatively affecting my life, but rather they think that their brain is different in some manner that causes them this kind of anxiety. I think it's the kind of, that's why, the chemical imbalance idea was, so appealing and intuitive to a lot. So it's not just that, it's not just the fact that you're depressed and your low mood is negatively affecting your life, but rather, hey, there's something different. There's something abnormal going on in this situation, right? So how to talk about that idea of abnormality is the tricky part, and the DSM has just kind of chosen to talk about it in this, commonsensical, folk psychological way. So the more scientifically inclined or naturalistically inclined people think that maybe that's okay as a starting point, but really, I think we have better ways of talking about abnormality. And again, we can talk about either, breakdown of evolutionary mechanism. We can talk about biostatistical deviation from species typical functioning. We can talk about quantitative deviations in brain circuit change, et cetera, et cetera. So they say, hey, if we want to talk about abnormalities, then let's do it in a rigorous manner rather than just using this kind of, folk psychologically commonsensical language.
Got it. So, suggestion number one, clarify the DSM concept of, quote, mental disorder. Follow up, mechanistically speaking, how? What do you want the DSM to do? Just give a definition in the intro to the DSM, include it as a criterion to every diagnosis, etc.
I think the main thing would just be being very clear about what that means in the introduction. Now, DSM, to its credit, it does offer a definition of mental disorder, and it defines it as a syndrome that is a result of dysfunction in biological, psychological, developmental processes, and is usually associated with, distress and impairment, as not entirely due to conflict between individual and society. The problem is that it doesn't define the term dysfunction further. And that's where the meat of the philosophical and scientific differences come in. That's where a lot of philosophical and scientific debate is. So someone just reading the DSM would not know what does DSM mean by that. Now, if you look at the criteria and you can get a good sense of it, you realize that, okay, kind of like, what dysfunction means in the DSM context is this kind of just, this general sense that anxiety is excessive or something is out of proportion or something is persisting beyond what we would expect, right? So, and this is also kind of like in some of the authors and people who have been behind the DSM. So, for example, Kenneth Kentler, he confirmed, when I interviewed him as part of my Conversations in Critical Psychiatry series, he confirmed that the idea of dysfunction in DSM is commonsensical in the same way as we're referring. So insiders know, but a lot of people don't know. And what happens is that I think anytime a new diagnosis is added to the manual, it generates this kind of controversy. I guess the most recent example would be prolonged grief disorder. When prolonged grief disorder was added in DSM-5 a couple of years ago, and so people are like, oh, so psychiatry has now declared grief to be a disease or kind of like a medical problem. So the backlash is not around the fact that yes, there are people who have persistent grief and that negatively affects their life. I mean, I don't think anyone would deny that. No one would deny that, yes, there are people who suffer for prolonged periods and that negatively affects them. But rather, I think people who challenge the inclusion of that diagnosis, they think that there's a stronger hypothesis being made. Something stronger is being said about grief, and they don't like that hypothesis. They don't like that we are talking about grief in those terms. And so I don't think the general public appreciates what the DSM meaning of dysfunction is. The very least DSM can do is that at least make it very clear as to what they're talking about.
I reluctantly want to stay with this first suggestion for one more question because I think it's so important, and I think you probably made it your first suggestion for a reason. What are the consequences for the field if we don't get this straightened out?
I think the consequences is just continued muddled discussion around medicalization, and psychiatry would kind of remain trapped in these futile debates of whether we are medicalizing suffering unnecessarily and whether we are conceptualizing psychological and mental health problems as diseases or as neurobiological abnormalities. So I think it would continue to generate this tension where a lot of people would continue to think that psychiatry makes these neurobiological reductionistic kind of assumptions about mental suffering, and then they would react against those assumptions, and so I think a lot of this debate is unnecessary, and I think it could be resolved if we were simply clear about the concepts we are using.
Yeah, and I think if we clarify this concept and we clarify that when we say someone has a mental disorder as defined by the DSM, they don't necessarily have a discrete pathological process that's associated with that disorder. We expand the role that psychiatrists can play in helping people to make meaning of their lives, we maybe expand the role of psychotherapy because we're not just assuming that everything needs to be targeted in a very neurobiological way. I think I'll just speak in personal experience. When I've made major changes in my life that have led to significant changes in, let's call it quality of life, it's usually driven by psychiatric symptoms. And in some cases, maybe even a full blown major depressive episode. And so I think by clarifying this, it allows people to understand that just because they can find themselves in the DSM, it doesn't necessarily mean that the only intervention is biomedical in nature, and that things like psychotherapy can be really important for helping them make sense of things. It's not that they have this monkey on their back that they need to get off of their back by taking some pills.
Yes, and I think the other thing is that I think the dysfunction idea I think conveys a sense of brokenness. I think it can conveys that something in the mind or in the brain is not doing what it is supposed to. It is broken in some way. It is malfunctioning in some way. And again, there's a grain of truth to that. But we have also seen that many psychiatric symptoms do have some kind of adaptive significance, do have some kind of a signaling role to play. Their content can be analyzed. And so I think it's also important to clarify and move away from these assumptions of brokenness that dysfunction inadvertently conveys.
Moving on to suggestion number 2. Suggestion number 2 is indicate the degree of empirical validation for all diagnoses. So, intro to this, Dr. Aftab, how is the DSM like a house of mirrors?
I was trying to think of analogies to use in this regard, and I settled on
I like
House
it.
of
That's why
Mirror.
I'm asking. I
But
love
it's
it.
all it's in an inverse way. I mean, I think usually what happens in a House of Mirror is that I think it distorts and exaggerates into things into proportions that they are not usually exaggerated ones. So I think what is happening in the case of DSM is that it's like an inverse House of Mirror where it's equalizing everything. It's kind of like taking someone big and someone small and it's just making them the same size. And the reason I think is that is just, it presents all diagnosis on an equal footing. You open the manual and it's just like, hey, here are these formal diagnoses. It doesn't say anything further about whether there's a hierarchy of diagnosis or some diagnoses are, more empirically supported than others. You just have these diagnoses. And so intermittent explosive disorder is on the same footing as schizophrenia, even though they are, continents apart in terms of how much evidence is behind them or what kind of empirical support do they have. This kind of silence around the empirical status of categories also hurts the profession because it gives a distorted idea to many clinicians as to public about the standing of these diagnoses and whether some of them are more kind of well supported than others. It also obscures the degree of uncertainty and controversy around certain diagnoses, and whether some diagnoses are simply a loose way of referring to some, isolated symptom, or whether they are part of a, bigger problem. So I feel that that's an issue as well, and I think it also becomes permanent in the context of comorbidity too, when people have a number of different diagnoses, and and patients don't necessarily know which diagnosis is more paramount or is more well supported than others. For reasons of scientific integrity and also kind of clinical, integrity and facilitating more transparent discussions around this. I think one easy way of simply, finding some way of communicating, the degree of empirical support behind different diagnostic kind of frameworks, diagnostic constructs. And that way, the constructs that are relatively weaker, we can all be open about their weak status as a field.
And maybe they're not scientifically validated, but they have utility in other ways. They're needed due to some clinical reality where we need a descriptor of this, etc. So you're kind of suggesting that the DSM maybe design a system for indicating to what degree this diagnosis is empirically validated, maybe some sort of a composite score, system of letters, maybe an index, etc.
Yeah, I mean, I think I didn't intentionally commit myself to any particular way in which we could,
Yeah.
do that.
Yeah.
And this actually, I think, this relates to a bigger issue, the issue of kind of, validator convergence. So the way we talk about validity of different diagnoses is in terms of these different lines of evidence that were originally proposed by psychiatrists Robbins and Guzay in 1960s, 1970s. And then they were kind of clarified by the psychiatrist Kenneth Kendler. And Kenneth Kendler was also the one who used the terms validator. So these refers to things like family history and genetic associations and pattern of clinical symptoms, associations with other disorders, so patterns of comorbidity, history, neuropsychological associations, treatment response, longitudinal course of illness. So we have these different lines of evidence to think about, do different conditions differentiate on them? And by and large, I think, most psychiatric disorders show differences on them. There's a lot of overlap, but on average, they'll show differences. So for example, the prognosis of schizophrenia and bipolar disorder, both of them are very broad and overlapping, but on average, bipolar disorder has a favorable course of illness compared to schizophrenia on average. We can think of, if you look at cognitive functioning, on average, schizophrenia patients have worse cognitive functioning compared to, major depression patients, etc. Now, because of that overlap, it has limited predictive value. You can't use someone's IQ or you can't use course of illness to infer back what their diagnosis is because it's not reliable enough in terms of making that prediction. But because there are average differences associated with that, it points out that, all right, there's something going on. These diagnoses are kind of pinging or indexing slightly different configurations of problems. The challenge is that these different lines of inquiry, things like family history and brain associations and course of illness, treatment response, they don't all align very well. They don't all align, neatly or even sufficiently robustly. So they all kind of a little bit misaligned and they present in kind of, they point in different directions. And there is no optimal way in which to resolve that misalignment. There would be if there was a central etiology, if there was a central cause like Huntington's disease or measles or, something like that, then everything would all kind of fit together. But in the absence of a central cause, it depends on you which validators you want to prioritize. Do you want to prioritize genetics? Do you want to prioritize course of illness? Do you want to prioritize treatment response, etc.? And there's actually a really wonderful paper by Ken Kendler and Miriam Solomon talking about this problem of convergence validators, and they actually show that there is no adequate resolution, that, from a philosophical and scientific standpoint, there is no optimal resolution to this issue of how to compete, validators that don't align very well. So we're stuck with that. So I think any kind of composite that we create would run into that issue of convergence, into that issue of how do we weight different lines of evidence that are not, on paper equal. Maybe an index can do a good enough job, but even if we don't have an index or a composite store, I think finding some other way of conveying the strength of evidence, I think would be useful, and it would be, I would strongly encourage the field to consider that.
I can't wait to listen through this episode again so that I can catch everything you just said. But I did read the Kendler and Solomon paper, which shed a lot of light for me. And I have to have at least one of them on the podcast at some point. And I think I would say that's why I'm not confident that we are going to come to a unifying scientific explanation for mental disorder, and why we are never going to get to what we used to imagine the DSM might sometime be. We are going to take a quick break. When we come back, we'll do suggestions 3 through 6. It's always funny for me as a podcast host because I never know what you're doing when you're listening. Are you grocery shopping, going for a run? Are you doing dishes, walking your dog? I know you're busy. I'm busy too, and that's why I work hard to make sure that I have the tools I need to stay organized. When it comes to clinical documentation, Simple Practice is the perfect organizational tool for busy folks. Simple Practice is an all-in-one EHR that is HIPAA compliant, HITRUST certified, and built specifically for therapists. Simple Practice brings scheduling, billing, insurance, and client communication all into one place, so you're not juggling multiple systems to run your practice. Simple Practice makes documentation less daunting and less draining so that you have more time and energy to spend with your patients. And if you're just starting out or growing your practice, there's also a credentialing service that takes the headache out of insurance enrollment, which honestly can be a huge lift. Simple Practice is trusted by over 25,000 health and wellness professionals, and you can really feel that it is thoughtfully built for our work as psychiatrists and therapists. If you're ready to simplify the business side of your practice, now is a great time to try Simple Practice. Start with a 7-day free trial and then get 50% off your first 3 months. Just go to simplepractice.com to claim the offer. Again, that's simplepractice.com. As a podcast listener, you know that podcasts are perfect for adult learning. Adults know what they need to learn and they know how they want to learn it. And for me, when it comes to studying for board and licensing exams, there is no substitution for doing multiple choice questions. If you are studying to beat an exam, I think you should use Beat the Boards. Right now, Beat the Boards is offering bootcamp listeners a great deal. You'll get free access to over 4,400 exam style questions for USMLE Step 2 and over 4,500 questions for USMLE Step 3. Again, this is not a discount code. These exam questions are totally free for bootcamp listeners. I use Beat the Boards to study for my own board exams, as well as several other services similar to this, and I really did find that Beat the Boards was the best by far. Go to beattheboards.com/bootcamp to sign up and get your free questions. That's beattheboards.com/bootcamp. Welcome back. Dr. Aftab, your third suggestion, I think, is sneakily also the most subversive. You think that the threshold for each diagnosis, so for example, 5 out of 9 SIGME CAPS, 4 out of 7 DIGFAST for a manic episode, you think that this threshold should come with an explanation as to why this number. Now, my longitudinal understanding is that this threshold is in reality quite arbitrary. I know there's a great story, maybe it's apocryphal, I don't think it is, about the creation of DSM-3 and the chair, Robert Spitzer, says that he would get experts in a room and have them argue about what the threshold should be, what the number of symptoms should be, and the duration required for each illness. And he would check in with them around noon, and they would be angry and they would be arguing. And then he would feed them sandwiches. And he basically said that the conversation never went past 1:30 p.m. because, as we all know, people tend to agree when they are not so hungry and crabby, which I love that story because I think it speaks to the arbitrary nature of the cutoffs that we sometimes refer to as a part of an infallible Bible, which is just like astronomically silly to me and a major driving force for why I do everything that I do. So, don't you think that the APA would just have to write vibes or perhaps expert consensus for all the thresholds? What am I missing?
It may be the case that we have to write vibes for a lot of diagnosis, but I think in some cases we do have more data, or we have kind of some lines of evidence pointing towards a certain threshold. The challenge is that right now we just have no formal recognition of why the threshold is what it is, which means that even in situations where we do have some legitimate line of reasoning behind it, that remains unknown, and no one quite knows what that threshold is supposed to do. So, for example, I think, when prolonged grief disorder was included in the DSM, its threshold was supported by a number of statistical analysis about the sensitivity and specificity of the diagnostic criteria. And so they conducted analysis of kind of like, how many criterion items do you need to get a sufficiently good balance of sensitivity and specificity. And so the threshold that they selected for prolonged grief was in some ways, informed by the scientific and clinical research that was available to them. Now, that has not been the case for all diagnoses, especially in the ones that have been historically present in the manual, and the original inclusion might have been based on much more clinical impression. You were mentioning about some of the stories, with Robert Spitzer. One relevant to the diagnostic threshold for depression is when Daniel Carlett interviewed Robert Spitzer for his book, and he asked him about why 5 out of 9 criteria for depression, and Spitzer said that it just seemed about right, that 4 seemed too low and 6 seemed too high and 5 just seemed about right. Now, Spitzer was also being a little bit flippant. They had some data as well that they could analyze, but there was still a lot of judgment call involved in what the threshold is going to be. My overall frustration, my bigger frustration with this issue is that I think because when we don't specify what the threshold is doing, we also fail to optimize it in a manner that is needed. Take an analogy with hypertension. Blood pressure is also a dimension. It's a spectrum. Everyone has a systolic blood pressure and diastolic blood pressure. There are no natural discontinuities in blood pressure distribution. If you plot the blood pressure distribution of the population, you'll get a continuous curve. And to some degree, the values that we pick, on the blood pressure continuum are semi-arbitrary. If you pick historically, for example, 140/90, it has changed now in some situations, but let's go with 140/90. 140 is not magically different than 139 or 141, but as a rough guide, it kind of works. But the 140 was selected for very good reasons, and this has to do with the practical nature of the categories. What we are trying to do with essential hypertension is that we're not trying to identify people with quote unquote abnormal veins and arteries or abnormal venous circulation. Rather, we're trying to identify a kind of blood pressure values that predispose people to higher risk of cardiovascular disease in the future. So we want to reduce the risk of stroke. We want to reduce the risk of heart attack. So we have a clear goal. We want to reduce future incidents of cardiovascular disease. We can then look at the data and optimize the threshold based on that data, right? So we know clearly what we are doing. We can also kind of optimize the threshold based on at what point do the benefits of the treatment outweigh their harm. So if you look at the hypertension guidelines, they refer these judgments. They refer that we looked at this and we decided, people felt that, at this threshold, the benefits of treating with a hypertensive medication or through some other intervention kind of outweigh the risks that are there, and and if you keep the blood pressure below this, future risk is lower. So you know what you're doing. Do we know what 5 out of 9 depression is doing? I don't know. I don't think a lot of other people know, right? And so if we don't know, we can't optimize it. And once we realize we don't have to accept some random guess as a threshold, we can actually optimize these thresholds to achieve the things we want to do, then a whole new space of clinical and scientific inquiry opens up. You can ask, what kind of diagnostic threshold makes sense where, most people would experience, let's say, benefit from a depression medication, kind of like, what's the threshold at which the response to, significantly separates from placebo, or where benefits begin to outweigh potential risks of the treatment? What is the threshold at which a person is more responsive to psychotherapy? What is the threshold where we seem to be able to differentiate people with a certain psychological profile or certain pattern of comorbidity from others, right? So we can ask all of these questions, but we can't ask them if we first don't even know what the threshold is about. In some other cases, the threshold can be somewhat kind of pseudo-specific. So take generalized anxiety disorder, for example. So, right now, the time threshold for generalized anxiety disorder is 6 months. That kind of anxiety has to persist for 6 months or more to qualify as generalized anxiety. And the reason behind that is that the authors of the DSM wanted generalized anxiety to refer to persistent cases of anxiety that are not situation limited or transient or self-resolving. So they did not want GAD to capture cases in which people are anxious because they're going through a divorce or they're just going through a stressful situation. And they felt that if a person has been anxious for 6 months persistently, the odds are that they have something more chronic going on, and this is not just situational. So in that case, instead of coming up with this pseudo-precise number of 6 months, you can just say anxiety that has been persisting for several months and is going to, persist beyond, situational stressors or things like that. And ICD used more vague language for GAD. ICD said kind of anxiety that persists beyond a couple of months rather than specifying a 6-month period. So you can ask all these sorts of interesting questions, and you can also, instead of making just a blunt decision that we're going to make it 6 months for everyone, you can also empower clinicians to make that judgment. You can have clinicians decide, when an anxiety is explained by situational circumstances and when is it explained by something more persistent, like, elevated neuroticism or other kind of thing.
Oh, I have so many follow-ups on that. I think one thing it's making me think of is how artificial intelligence is going to be involved in this
Yeah.
process, because we're talking about like huge data sets and trends and really interesting specific questions that you'll be able to get from it. And then also, if we are going to empower clinicians to use the DSM more as a guidebook and a set of tools to choose from rather than a Bible and a prescriptive guide, are we also then making the DSM more subjective because we're relying on all these different clinicians' subjective judgments? I think the list goes on. Any final thoughts on number 3?
Yeah, I think one thing I'll say is that I think clinicians already are kind of, they're not really taking DSM thresholds very strictly because they don't see the value. They don't see why we have to respect those exact thresholds. So what is happening in practice is that clinicians are using distress and impairment as thresholds. So It doesn't matter how many symptoms of anxiety you have or how long you've had them. If you are significantly distressed and impaired by them, that's good enough for a psychiatric clinician, right? Same thing with depression. So in practice, distress and impairment have become the de facto threshold kind of markers, and people generally disregard the whatever exact symptom count or the time threshold that DSM recommends.
It's so hard to try to put words in your mouth, but are you sort of saying you want the DSM to catch up then to what's actually happening in clinical practice?
In one way, yes. I think the reason clinicians are disregarding DSM thresholds is because they don't know what the threshold is doing or what is optimizing. And I think, and if DSM made it clear, they could actually make a case for why those thresholds should be, taken more seriously than they currently are. I think it also opens up a plurality of threshold. We don't have to have one single threshold. We can have different thresholds depending on the context or depending on what we are trying to do.
Wow. Yeah, absolutely. And it speaks to how the DSM is used for research, for clinical practice, for insurance billing, for deciding if someone is not guilty by reason of insanity. And these are all very different societal roles and maybe would require different criteria for each diagnosis. Okay, suggestion 4 is acknowledge gaps in the descriptive schema. So I love this one. It's amazing to me how many patients I see in clinical practice that clearly meet criteria for however we want to define a mental disorder. They're experiencing that dysfunction. Maybe we could even say that whatever is happening in their life, or I would even go so far as to say in their neurochemistry, is clearly and obviously atypical, but they don't actually clearly fall into any specific DSM category. So I end up with a lot of unspecified diagnoses. Practically speaking, what is the problem with an unspecified diagnosis?
I think the biggest problem is that it basically creates a lower class of diagnosis. It kind of gives the impression that, hey, there's this group of real, legitimate, true diagnoses that deserve to be taken seriously and that, we do research on and that everyone talks about. And then there's this second class of citizens that just kind of, they're just wishy-washy and maybe wastebasket, and there's no research funding dedicated to them. They're just like, there's no formal discussion of them. So I think there's this there's this intellectual incentive to disregard them. There's also not quite a sense of, well, from a patient perspective to them, if someone says you have bipolar disorder, they kind of know what to make sense of it. But if someone tells them you have unspecified mood disorder, what does that mean? How do you kind of build up some kind of a coherent narrative around having an unspecified mood disorder diagnosis, right? Or unspecified anxiety. So I think it creates all these kind of problems. And it also, I think, means that if large portions of our patients are meeting unspecified criteria, it means that those patients are not represented in kind of research being conducted. They're not represented in search for treatments. We are basically operating in ignorance about optimal treatments, what kind of adjunctive medications would work. If a medication works for a specified category, would it work for unspecified? Oftentimes we extrapolate, but it's all inference. We don't know. So I think it creates this situation where no one is incentivized to study it very well. No one is incentivized to take it very seriously. The people are discouraged from diagnosing it. And it creates pressure to diagnose those people as having a specified diagnosis.
See it all the time.
Yeah. So a lot of people, for example, who get diagnosed with major depression in primary care settings don't actually meet the DSM criteria for major depression. But, from a primary care perspective, it doesn't make sense to give someone unspecified, depression if the person is suffering kind of enough. So the specified categories get bloated in a way that kind of becomes problematic and invites skepticism. So think, for example, of what's happening with ADHD. We don't have a general category for diagnosing focus difficulties and inattention difficulties that is not linked to neurodevelopmental onset. So in order to give someone an ADHD diagnosis, we have to say, you've had this problem your whole life. It started when you were a child, and it comes with all of these neurodevelopmental conditions. I can't just, there is no a general, cognitive or, disorder, a general inattention disorder, category that I can use. So But the reality is that we have a lot of adult patients who have genuine difficulties with focus, concentration, motivation, reward, etc. And they're struggling to function and they need some kind of help. They often respond very favorably to clinical treatment. But in order to get them treatment, we have to pretend collectively that they all have ADHD, right? So that's another, I think, example of how having gaps in formal schema puts kind of unnecessary pressure on existing categories, and those categories then become bloated, and then people can become cynical and skeptical about them. They can start saying, "Oh, everyone is getting diagnosed with ADHD, so maybe it's not a legitimate diagnosis, maybe it's not as solid." Versus if we had a more accurate, let's say, dimensional way of categorizing people with their attentional difficulties, then we don't have to pretend that everyone has a neurodevelopmental onset and we can still treat the people we want to treat.
Sorry, what'd you say? I got a notification from TikTok. No,
Yeah. Oh, yeah.
I mean, it's absolutely right. It's common
Yeah.
sense that we're
Yeah.
living in a world where it's ding, 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 vibrate, vibrate. Like the world is exploding somewhere else, but right now I need to do it's what a sophisticated way to understand something that all of us, I'm going to say psychiatric clinicians and everyone else in the world is experiencing all the time. Thank you for that refreshing take. I totally agree. So, what should the DSM do about this?
Well, I think the first thing, I think this relates to appreciation of dimensionality and the cutoff point that we were talking. What is the value of saying that, hey, people above this threshold have some kind of specified diagnosis and people below this threshold don't deserve a proper name? If things genuinely exist on a dimension and on a spectrum, and there are people below that threshold who are genuinely suffering, then why do we want to play this game? Why do we want to, insist on some kind of, weird threshold? Why not just say that, hey, there's this spectrum of these issues, and anyone who experiences, a distress and impairment along that threshold is, deserving of treatment or worthwhile kind of like, of recognition, right? So I think the first is I think this lack of alignment between, you know, what do we want the threshold to do, and what kind of recognition do we want in the clinic? So I think it reinvites that kind of like question. The second thing is that I think I think we should be more clear about recognizing that there are gaps in our formal schemas, and we need to have a discussion collectively about what to do about those gaps. When I was in psychiatric training, at that time, I was very much influenced by the work of Alan Francis and some of the other people who were talking about overdiagnosis. And I'm still influenced by that. And I think they made a lot of good point. But over time, over the course of 10, 12 years, I have actually come to take the view that DSM and ICD are actually conservative manuals that,
Wow.
they haven't broadened diagnosis enough, and the reason I say that is because, we have a lot of patients in the clinic that just don't have a specified diagnosis. So clearly, the domain of treatable and recognizable clinical problems is a much bigger domain than the domain of specified problems, right? And again, kind of reiterating that point, that does lead to overdiagnosis of the specified categories because we're just not paying attention to the rest of the people. So we need a kind of, one of the basic things we should expect from descriptive classification is that it should not have holes in it. Then, a descriptive schema should be able to describe any potential kind of clinical problem that comes, right? So, if we wanna have a descriptive classification, then why are we doing a half-ass job at it? Why do we have a descriptive system that cannot even describe large chunks of people we see in the clinic?
Why not adopt a more dimensional approach where we actually can describe exactly what we're seeing and not just lump people into categories that don't mean anything?
Yes, yeah, and I think this is a bigger problem in the context of psychotherapy. Because I think psychotherapists see all kinds of mental health problems, and many of them are not gonna fall into specified categories, but they're still forced because of the way healthcare system is designed to use one of those kind of specified categories. So they have to call it something, maybe adjustment disorder or mood disorder or whatever. They have to give it some kind of a name, and again, it generates its own weird and odd incentives in the context that um, that the full range of mental health problems has to be filtered through this small set of categories that cannot do justice to it.
Yeah, I think maybe this is where Alan Francis's pragmatism kind of shines through. You're not saying we should be diagnosing more people that could be considered normal and necessarily putting them on medications. You're suggesting that we overhaul the whole system and have a more sophisticated understanding of the dimensional landscape so that people who maybe are more toward that normal range might get interventions that are more appropriate for them, like psychotherapy. And so that when we are deciding that we need to place a label on a patient, we actually have labels that work instead of, again, using what you, I think, described as a wastebasket diagnosis.
Yes. Yeah. Yeah. I agree.
Okay. I love the mothers in my life, but Mother's Day is always a little bit stressful for me because I never know how to pick a gift that will make these mothers feel appreciated in the way that I want them to feel appreciated on Mother's Day. So if that's you, let me give you a suggestion. What about a robe and slippers from Cozy Earth? Cozy Earth's robe and slippers make the perfect Mother's Day gift, and I love that Cozy Earth backs its products with a 100-night sleep trial and a 10-year warranty, so you can try them with confidence. Head to cozyearth.com and use code BOOTCAMP for 20% off. And if you see a post-purchase survey, make sure to mention that you heard about Cozy Earth right here on Psychiatry Bootcamp, because home starts with mom. If you're feeling overwhelmed, stressed, or burned out, the Oasis Psychiatry Conferences from the American Physician Institute are for you. Oasis focuses on you, your well-being, your career, your future. Yes, Oasis covers psychiatric disorders with practical, real-world guidance, but Oasis goes further, helping you reset and recharge through wellness talks, group discussions, and guided imagery sessions led by Dr. Jack Krasuski. It's a true oasis from burnout. Visit masterpsych.com to learn more about Oasis Psychiatry Conferences and enter code BOOTCAMP for an exclusive 10% discount. That's masterpsych.com. Offer code BOOTCAMP to find your oasis. So this next one is loaded, so we're going to take a deep breath together. We're going to talk about the Hierarchical Taxonomy of Psychopathology. What is the HiTOP is kind of the acronym for it. What is HiTOP, and why do you think that it should be included in DSM's appendix?
Yeah. So HiTOP is an alternative classification of mental health problems, or psychopathology, as the term goes. It's developed by a consortium of quantitatively minded psychologists and psychiatrists who are interested in symptomatic classification, symptom-based classifications, but they want to go about it in an empirically rigorous manner. So kind of what has happened in DSM is that DSM relies on clinical patterns that have been recognized by clinicians over the course of history of the field. So, clinicians recognize that, hey, there's this group of people that have psychotic symptoms and deteriorating course, and we'll call it schizophrenia. And, there's this group of people with mania and depression, and there's this group of people who seem kind of generally anxious, we'll call them generalized anxiety. And there's this group of people who have, depression. And that has worked. That does a decent enough job. It works well enough that you can actually, match people with the, roughly, appropriate treatments. They showed average differences on validators. But if you look at the symptom distributions from a statistical perspective, the separations between those conditions disappear. So from when you look at actual real world patients and you see kind of, what symptom patterns, major depression does not emerge as a distinct statistical cluster from generalized anxiety, but rather it's a mishmash of symptom that does not distinguish, right? Similarly, kind of schizophrenia does not emerge as a distinct condition among psychotic disorders, but rather what we see is that we see a psychosis spectrum, and that has, and different people along those spectrum have different varying levels of cognitive functioning, varying levels of negative symptoms, those kind of things. So people who have been interested in what is called structural evidence or quantitative evidence or statistical evidence have been unhappy with the categorical schema of the DSM. Initially, there was hope that maybe DSM-5 would take this seriously, but when DSM-5 came out, and those scientists realized that this was not happening, they were like, enough is enough. We're taking matters into our own hands. So a grassroots consortium was created, and the first HiTOP kind of classification was formally presented in 2017. And so it relies on statistical patterns of comorbidity, and it generates kind of latent factors that explain proportion of shared variance among these symptoms. So what you get is that you get a hierarchy of symptoms at different levels of generality. So think of it as a pyramid, if you want, or like an inverted tree. So at the bottom you have symptoms and traits, and if you statistically analyze them, there are some factors that emerge. So for example, depression symptoms and generalized anxiety symptoms, as I mentioned, they don't separate. Rather, they form a cluster that we call the distress factor. And problems like different kinds of phobias and social anxiety and some of the other ones, they cluster into a fear subfactor. And we get a factor of kind of sexual problems. And then those subfactors congregate into higher order factors, which explain a larger portion of that variance. So you get spectra. So you get internalizing spectrum, which covers a very wide range of kind of mood problems and kind of anxiety-related problems. There's a somatoform spectrum. There's an externalizing spectrum that covers things like impulsive behaviors and ADHD-related issues and substance use kind of related issues. There's a psychosis spectrum or a thought disorder spectrum that emerges. So you get these 6 spectra, and any particular patient will have a certain value along those spectra. So any psychiatric patient, they will have a certain value on the internalizing spectrum, a certain value on externalizing spectrum, a certain value on thought disorder spectrum, etc. And then at the highest level, all of these spectra have a common statistical factor that is known as the general factor of psychopathology. So there, in a statistical sense, there's a latent factor that explains common shared variation among all mental disorders, and that represents the increased likelihood that if you have one categorical diagnosis, you're going to have a different categorical mental health diagnosis too. So in a statistical sense, there's something shared by different mental health problems. In a similar way as, if you think of intelligence, so there are different types of intelligence and different aspects of intelligence, but in a statistical sense, these different types of intelligence share something in common. It's the G factor of intelligence, or the IQ score, right? So it's the shared kind of variance of different aspects of intelligence that is captured by the G factor. So in a similar sense, when it comes to mental health problems, there is something that all of these mental health problems share, statistically speaking, and that's the P factor, or the general psychopathology factor. And these dimensions are very well supported by statistical analysis of large data sets. They are replicable, and they associate with a variety of traditional validators. So these spectra differentiate on kind of genetics, they differentiate on course of illness, treatment response. So SSRIs are more effective across the internalizing spectrum, for example. So they capture some of these larger associations with the two much better than the DSM categories. And so the idea is that instead of assigning people these categorical labels, every psychiatric patient gets a dimensional profile along those dimensions. So everyone has a certain internalizing score, externalizing score, thought disorder score, somatoform score, etc. And this is similar to the kind of dimensional model of personality disorders that was developed before that, and that is in the appendix of the DSM. So if you remember, there's the alternative model of personality disorders, and that describes personality disorders along 5 dimensions. There's neuroticism, extroversion, detachment, psychoticism, etc. So instead of saying that this person has narcissistic personality or this person has borderline personality, you can take that clinical presentation and you can say this person is high on neuroticism and high on antagonism and high on detachment, right? Because in reality, personality problems are not arranged into packets. They are arranged along dimensions, and we can describe those problems along those dimensions. So we can create a dimensional profile of personality problems. And that dimensional model of personality problems is empirically well supported, has a lot of research behind it. And that is why it was included in the appendix of the DSM as hey, there's this alternative way of thinking about personality. And later on, it became the dominant model for ICD-11. So ICD-11 adopted the dimensional model of personality disorders. And I think research has, accumulated to a point where we can say with confidence that we are doing something right with this dimensional approach, that, this is statistically robust. It captures a lot of validator association that we want, and it bypasses the categorical thinking and forces us to think about the rich dimensionality of every patient. And it does not have the same kind of threshold problem as the kind of traditional DSM, because again, along any dimension we can pick the threshold that we want. Right now we're using population level norms, so you can using T-scores. So how many standard deviations are you away from a population level norm for internalizing symptoms or externalizing? But you can easily switch to disability based thresholds or impairment based thresholds or treatment based thresholds, etc. So that's why I recommended that HiTOP should be in the appendix, because I think it would be a clear recognition that we have multiple different ways of thinking about classification, and they offer different advantages. I think the traditional DSM categories have the clinical advantage that they are familiar to clinicians, and there's a long history of clinicians working within that. But we have a robust statistical evidence that a different way of thinking about diagnosis is possible, and I think DSM should recognize that.
I don't feel the need to go over that. I think you explained that pretty concisely. It came together at the end, and I felt like I had a handle on that. Just with an eye on time, what is your sixth and final recommendation?
So I think the sixth one was generally kind of along the lines of increased transparency and public accountability, and in two ways. One is that DSM is by and large paywalled. People can just go on the APA website and read the exact criteria. The second thing is that people who work on the APA task force, majority of them tend to have some degree of association with the industry, pharmaceutical industry.
Of them, wow.
Majority of them, 60 to 70%.
Wow.
On the whole, and the APA has an internal mechanism where the task force members have to report those relationships to the APA, and APA then analyzes them and determines whether they pose an obstacle or no. But that data is not publicly released. So there is no public accountability in that sense. And I think given the importance that DSM plays in, healthcare bureaucracy and the system and public perception of these problems, I think the least we can do is that make the DSM accessible to the public in the same way as ICD is accessible. Anyone can go on the WHO website and look at what the ICD criteria are, and that signals that, hey, we take this seriously. And in the same way, although I think there are critics out there who think that the pharma influences how DSM, decides and, minutia of criteria. I don't think that is true. I don't think that the pharma influences driving, the decisions that get made. But the mere fact that, APA is not transparent about that, it allows people to speculate. And I think in an environment where trust in medical authority is already deteriorating, I think, the more public accountability we can have and transparency, the better it is for the legitimacy of the manual and the profession.
Dr. Aftab, thank you for that summary. I couldn't agree more. I think it's a pretty simple recommendation, but a very important recommendation to increase access and transparency. I totally agree, especially considering where we are as a culture. Do you have any final thoughts for our Psychiatry Bootcamp audience?
I would just encourage, again, thinking about the hidden assumptions behind diagnosis and classification, and kind of asking what it is that we are doing when we use words like disorder and dysfunction, when we use certain diagnostic thresholds, when we use specified criteria. So paying attention to conceptual assumptions, paying attention to patient narratives and how diagnosis influence patient perceptions, and then opening oneself up to the plurality of ways in which we can talk about mental health problems and approach issues of classification.
If you want more of this, we will link Dr. Aftab's work in the episode notes, and you can go back to Season 1, Episode 1, where we launched Psychiatry Bootcamp with Awais Aftab. Thanks for joining me, Awais. Wonderful to see you again, and best wishes for the future, and maybe you'll be the chair of DSM-7.
Thank you, Mark.
Thanks for listening to this episode of Psychiatry Bootcamp. I hope you enjoyed the show, and like me, I hope you enjoyed listening to this episode several more times so that you can soak up all of the wisdom that Dr. Aftab just shared with us. If you are enjoying the show, I'd love to know what you think. You can connect with us on TikTok or Instagram at PsychBootcamp, or you can email me, mark@psychiatrybootcamp.com. Visit psychiatrybootcamp.com to sign up for our new newsletter, and you can connect with the rest of the Human Content Podcast family on Instagram and TikTok at Human Content Pods. Thank you for all the reviews. If you've taken time to leave a review on Apple Podcasts, I'm going to read you a recent review that we got that says, "Good review for all clinicians. Clear, thought-provoking review of key psychiatric concepts, even for non-psychiatrists." And of course, the show is for everyone, not just psychiatrists. So I'm glad that our friends, this one is in internal medicine, are enjoying the podcast as well. You can find full episodes of the podcast on YouTube each week at Psychiatry Bootcamp. Thanks for listening. I'm your host, Mark Mullen. Our executive producers are Aaron Corney, Rob Goldman, Shanti Brook, and me, Mark Mullen. This episode was outlined by Josephine Turner, and Season 4 is produced by Matthew Braddock. Our editor and engineer is Jason Portizo. Theme music was generously donated by Cave Radio. You can find Cave Radio on Spotify. Other music is by Omer Benzvi. To learn about our program disclaimer and ethics policy, submission verification and licensing terms, and our HIPAA release terms, go to psychiatrybootcamp.com, where you can reach us with any questions or concerns as well. Psychiatry Bootcamp is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.